Um, Welcome everyone on board. Can you hear me? Is my voice audible to you? Can anyone respond?
Yes, sir.
Yes,
Okay.
sir.
Yes, sir.
So because usually when we ask some when we discuss some topic which is slightly different, we say that have you done this? But now I will ask in other way. Is there any anesthetist in the world who does not anesthetize a patient for appendicectomy? I think there will be no person. Am I right?
Yes.
Okay. So my concern is that if the word appendicectomy comes, someone tells that there is a patient coming for appendicectomy, what are the concerns or what are the things which you can expect? Please, I want you people to speak out, because otherwise it will be a useless activity. What will be the concerns in a patient going for appendicectomy? Munazza, will you speak out? Okay, why appendicectomy is done?
Appendicitis, I guess.
Appendicitis. Okay. So what you should expect in a patient coming for appendicectomy? Because
Yes.
the technique will be either
Patient could be
laparoscopic.
young.
I'm sorry, just a second, please. The technique will be either laparoscopic or open. So at the moment, I'm just bypassing the technique, and we will come back to it, because laparoscopic concerns we have discussed multiple times in separate sessions. Today, I will be focusing on like what you should be thinking or what you should be expecting in a patient who's having appendicitis, and they are telling you that we want to do appendicectomy. So what should be in your mind? Yes, please. Who was speaking?
Sir, it could be rupture of maybe possibility कि
Very
rupture हो
good.
सकता है. Second
Yes,
ये कि
try
pain
to speak out in English.
there may be a element of
Try to speak out
exaggerated
on
pain.
English, because there are some people who are not from our country. So just try to speak out in English. Okay, rupture, one thing. What else?
Exaggerated pain
Pain.
maybe.
Okay. What else?
Dehydration,
What else?
dehydration, full stomach,
Very good.
dehydration, full stomach,
Dehydration. Very good. Full stomach. Very good. What else? Dehydration because
Anxiety.
anxiety. Okay. Anxiety.
sepsis,
Very good. Sepsis. What else?
High grade temperature.
Like sepsis, yes, high grade temperature. Very good. Hyperthermia. Okay. Hyperthermia. And when we say sepsis, also perforated appendix. Okay. Leading to peritonitis. Okay. What else? Very good. Hyperthermia. Patient will be hyperthermia. So what will be the effect related to hyperthermia? You can chalk out. There may be like dehydration. Okay. And like all the effects of hyperthermia. Okay. Then what else?
Increase
Patient
oxygen
disease,
consumption in hyperthermia.
vomiting.
Vomiting. Just
neurologic disturbance,
Abnormalities.
yes, just a second. Please, one by one. Dr. Rukaiya, just take the lead, please. You said nausea and vomiting. Okay, so it lead to electrolyte imbalance as well as fluid deficit. Okay. Okay. So is there any difference between male versus female?
A female of a childbearing age can be expected to be pregnant.
Yes, pregnancy. Ectopic pregnancy. Okay. Or not
Ectopic or maybe ovarian cyst.
ovarian cyst. Okay, like it can be a misdiagnosis. Okay. Like I give you like clinically, because okay, a few words about diagnosis. How we usually diagnose the appendicitis? It's a clinical diagnosis. Okay. Plus, what investigations we do?
Ultrasound.
Ultrasound. What else? Please.
CT abdomen.
CT scan. Okay. What else? WBC count will be high. Okay. And of course, according to the dehydration and everything, the related test will be there. In addition to this, usually CT scan is the diagnostic one. In addition to clinical sign symptoms, ultrasound will be there, and one of them. And in ultrasound, the diagnosis may be changed. Like I tell you that my own sister, she was diagnosed to have pelvic kidney, while clinically they were thinking to have appendix. Okay, so even this can be something. So like you have to think about everything when you are having a patient which is coming for appendicectomy. Okay, because maybe you are not in a setup where they have done CT scan, or maybe only they are doing clinically or ultrasound and they are proceeding for it. So you can expect anything. Even appendicectomy can end up in having hemicolectomy. Okay, so you should be ready for everything. So these are few small points. And then if it is open, usually the incision is infraumbilical. Okay, it is one of the simplest to complex operation. Okay, it may be a very simple, the most junior doctor is being asked to do this surgery. Okay, laparoscopic I am just bypassing for a while, because laparoscopic, all the concerns of laparoscopic surgery will be there. Okay, so at the moment I am focusing on open appendicectomy and the general concerns which will be there. Okay, as an anesthetist, when we say full stomach, so actually, can we do something to rule out in 2022? If we listen that appendicectomy is coming as a point of care ultrasound, can we find something? We can find the residual volume in the stomach with POCUS, point of care ultrasound. Okay, if we are expert, or if we have like expert, like we are having this knowledge, we can just put a probe on the epigastrium and we can find the residual volume. So we can rule out whether this patient will be at more risk or less risk. Of course, NG tube is always a questionable thing, whether to pass it or not. If you are being asked to do it, of course, appendicectomy, usually they will not be doing asked. But for example, if they have made the patient NPO and there is diagnosis is not confirmed, maybe you will find to have NG tube. And whenever there is NG tube, you can expect that the lower esophageal sphincter tone will be gone and patient will be at more risk, actually risk of aspiration, because with the NG you can aspirate the liquid. Okay, but you cannot evacuate the solid particle. Okay, so you can only evacuate the liquid. So solid will still be there. So like this is something extra. Okay, some words about the analgesia. So what are in addition to the multimodal analgesia, okay, with the opioids and everything, what regional anesthesia techniques you can tell? Yes, please.
Tab block,
Tap block. Okay, alio inguinal,
quadratus lumborum,
quadratus lumborum. Okay, quadratus lumborum block, inguinal iliohypogastral block, local infiltration. Okay, usually you need to have the lower thoracic nerve roots to be blocked. We are talking about open. Okay, the traditional NCN. Okay, so then when we were talking about diagnosis, clinical features, I missed. Can we just mute the mic? Yes. So like yes, some words about role of opioid. Should we use opioids, or is there any pros and cons of using opioids in this scenario? By the way, world is going towards opioid-free anesthesia. Okay, so we should always rectus sheath block, no, because rectus sheath block is mainly for the midline NCN. Okay, if they are doing midline NCN darshan, then rectus sheath block will help. QL block actually, or tab block, because in this scenario there will be not much difference between tab block and QL block. QL block is more efficient. If someone asks you what is difference between QL, so QL block will cover the more of the like you can say the lateral branches. When we are doing it slightly anteriorly, the lateral branches sometimes are being missed in tab block. So that will be giving, but of course QL block is much more difficult to perform as compared to tab block. Okay, it's a deep block. So tab block in that reference is much easier than QL block. So opioids, any relationship, or any, if someone asks you that role of opioids in abdominal surgery. Actually, opioid act on gut. So the gut motility, so there is more chances of ileus. Okay, so this is true for all abdominal surgery. So there will be more chances of ileus. Okay, so if you are using too much opioids, that can lead to ileus. What other factors lead to ileus, development of ileus after appendicectomy or any abdominal procedure? Electrolytes, especially hypokalemia. Okay, dehydration, excessive manipulation. So like these are all things which you should be considering when you are doing this. So like anyone wants to ask any question, or anyone wants to add something to it? Yes, Dr. Ruqayya, Dr. Munazza, Dr. Shamail Fatima, anyone?
Why not epidural?
Epidural. Yes. Actually, usually NCN is very small. So if you are talking about the choices, yes, epidural is one of the option. Okay. But usually because of NCN is not that much big, so that for that reason, there will be not much reason to place epidural. Actually, in the surgeries, whenever where we are able to, because usually in the international standards, usually majority of time they are doing it laparoscopically. Okay, so when they are doing laparoscopically, there is no need for epidural. For laparoscopic appendicectomy, actually you can get a very good result even with TAP block. Okay. So otherwise, of course, this is the reason which I have told you. So epidural, yes, is one of the option. Can you do appendicectomy in spinal? Yes, please. Who said yes? And caudal, you know, in caudal there is sacral roots. Okay. So in adults, caudal block is always a challenging procedure. Okay. So you need to give a lot of volume, and because you need to cover up to T10. So in adults, you need to give a lot of volume. And in adults, caudal block is quite challenging to perform because of the ossification or landmarks. Because so that is see, but theoretically you can give yes, because caudal block is like epidural block. Okay. So epidural, yes. Spinal, what will be the problems? If someone asks you what level of anesthesia you need for appendicectomy, according to the incision, of course, but usually T10. Okay. Up to T10 you need. And if someone tell no, T4, what will be the reason for it? I will not hit you through the mobile. So please answer. Even if you are answering wrong, there is no problem. Because the mesentery, peritoneum, okay? So if it is involved, then you may need to have a higher block. If peritoneum stretch is the issue. And during the surgery, of course, whenever peritoneum and mesentery comes, vagal responses can occur. Okay. To prevent vagal responses, you should have a adequate depth of anesthesia. So because there is a big confusion that when vagal response occur, they decrease the depth of anesthesia. So actually, if you maintain a good depth of anesthesia, the vagal responses will be less as compared to like if bradycardia occurs, it means your level of anesthesia was not adequate. Okay. So it was a short topic. Okay. So, with reference to laparoscopic surgery, because there are a lot of sessions being done by me for laparoscopic surgery, well, I will just quickly summarize. You remember in 3 steps, and you can elaborate or increase your answer with it. First step is when the insertion of trocar occurs. Okay. So at that time, any vessel injury can occur and viscera can occur. So you can with this mnemonic of PV. Okay. And then the second step is pneumoperitoneum. Okay. So when they start pneumoperitoneum, at that time, what can occur? There can be carbon dioxide embolism. Okay. And then it can also cause these cardiovascular and respiratory responses, because there may be decrease in venous return, and there may be some vagal responses, so that can occur, and the FRC will be reduced. Tube, like all the tube can be migrated, so it can become endobronchial, and there will be increased airway pressures. Okay. And the third step is because of the third step is because of carbon dioxide absorption. Okay. So carbon dioxide absorption will be increasing CO2 levels in the blood, and it will cause the sympathetic stimulation. Okay. and it will cause tachycardia and blood pressure and all the effect on ICP and all the effect related to carbon dioxide. So you can broadly divide the effect of laparoscopy in 3 steps. Okay. Anesthesia machine and equipment. Unfortunately, you people don't see the group. So I'm there available for everyone anytime. And PowerPoints, you see the articles, you have articles and books for every topic. Unfortunately, you should be using some of your energy to make the presentations. It's not so difficult. But still, because I have access, I have taken the access for slide share, so I have that. So you can, I will, what specifically anesthesia machine equipment, you can tell me, I will send it to you. You can contact me directly via WhatsApp. Okay, visceral hypoperfusion with reference to, you are talking about RF, you are talking about visceral hypoperfusion with reference to pneumoperitoneum.
Yes, sir.
Okay, so before I finish, anyone wants to speak out, ask, discuss, speak, anything need to be added?
Sir, residual pneumoperitoneum effects in laparoscopic surgery post-operatively.
Yes, what will be that? Those, very good. Not only carbon dioxide, plus also water, saline. When they are putting a lot of saline to irrigate or something, this can occur and it can cause diaphragmatic irritation. Okay. So what they do, usually they spray local anesthetic. So it will be in the form of shoulder tip pain. Any other point, Munazza?
Sir, it lasts
Sir,
for
treatment for
few
that
hours
shoulder pain?
or few days.
It can last for few hours, I think, not few days. It
Okay.
ultimately will be absorbed.
Okay.
Sir, and
Yes.
what's the treatment for that? If a patient complains of shoulder pain, then
Actually, this is a refer pain. It will be because that's why they always, whenever they are doing laparoscopically, they usually put this one lidocaine. But your question is very nice because it will be just like any visceral pain because it's a referred pain. So you will be relying on opioids and that as something. Yes, Dr. Masood.
Oh, hi, thank you very much. My name is Masood Ahmed. I'm one of the consultant anesthesiologists. I just don't understand why somebody would consider doing a caudal or spinal for appendicectomy. I mean, it's just like, to me, it's just trying to complicate a very simple anesthetic management of this simple procedure. So, I must admit it doesn't make any sense to me
Yes.
even to consider spinal for nothing. Or caudal would be, it's from another planet. I mean, I just don't understand why even someone would like to discuss appendix with caudal or in most of the cases spinal. So it's a
Yes,
simple
Doctor.
procedure, lap appendix. You just give a GA and that's it. And
Yes.
why? I mean, there is a visceral element. You mentioned quite a few elements. And why would you want a referred pain to the shoulder tip with the irritation of the diaphragm in a patient who is not anesthetized and have just a spinal? And why would you want to complicate a simple thing? Because my understanding during my training was if you keep the things simple, you have less chances of getting into trouble.
Yes, absolutely fine, Dr. Masood. Actually, I will just like clarify one thing because in like some parts of world, people are doing appendicectomy purely in spinal. So that is actually the people who asked this question. Maybe in their mind, this is the reason because in Pakistan and in many part of world, they are doing actually it should not be done, right? Because we never do it. But in majority parts of world, even when I was in Pakistan, actually, unfortunately, in private setup, I have myself been forced to do appendix under spinal. Unfortunately, this is your point, and your concern is absolutely valid. Nobody will be doing caudal anesthesia and spinal anesthesia for like procedures like appendicectomy, especially if it is done laparoscopically. So thanks a lot for your comments. I hope, Dr. Masood, you agree. You want to add on something, please?
Yeah, no, absolutely. It's just I don't think I would do a lap appendix, even if I'm forced to do it under
No, not lap.
spinal, because
Open.
even open, I think you can do it as a desperate situation, but generally these are fit and well patients. So you like to use a preferred method of anesthetic management, which is a simple GA. It's a half an hour procedure to the maximum, maybe 1 hour when you're pushed. So spinal, I have never done appendix in spinal. So that's why I don't even think it need to be discussed. You discuss the stuff which improve the quality of patient care and quality of anesthesia you're giving to the anesthesia, and that's what should be discussed and promoted, in my opinion. But
Yes,
thank you
yes,
very
yes.
much.
You are absolutely right. You are absolutely right. And we never do it, and there is actually no need. Even in laparoscopic, even colorectal surgeries these days, they are not using epidurals, and because it's not needed. Even epidurals are not being used frequently if it is done laparoscopically. So I think I have just tried to highlight few of the points, and thanks a lot, Dr. Masood, for your input. So if anyone has any question, please feel free to ask, and then we will wrap up our discussion. Okay, so thanks a lot, all of you, for your presence, and we will come back with some new topic, inshallah. Okay, thank you very much. Thank you, Dr. Masood. Assalamu alaikum.
Thank you very much. Thank you for listening.